I'm Holly Stanley. I'm the Chief Financial Officer for Mid-Valley Hospital located in Omak, Washington. We are a critical access hospital and public hospital district. We also have one provider-based rural health clinic. And I have actually worked for Mid-Valley Hospital for 27 years. I started out there as a staff accountant and served in several roles in the finance department until I was promoted to CFO in 2015. It's been a wonderful experience. It's been challenging, but also rewarding. I lead 7 departments, and it's provided me the opportunity to wear many hats, and so I've really grown professionally in that spectrum. We net about $43 million annually, and we employ about 260 employees. We are the only OB provider in the county. Our payer mix is about 42% Medicare, and we're about 32% Medicaid. So that kind of gives you an idea of where I'm at, and then I will hand it off to David.
Hello, I'm David Rollins. I'm CFO at Prosser Memorial Health in Prosser, Washington. I've been doing this in this role for about 18 years in total at various hospitals. Prosser is critical access. We have 25 beds. We have about 400 FTEs, 100 million net revenue, 65,000 clinic visits, a little over 16,000 ER visits, 4,000 surgeries, 600 babies. We do that all in 2 ORs and 1 procedure room. Let me tell you, we no longer have an employee break room. It is now a pre-op room. And so we have tables in our hallway. We do have an employee break room, but it used to be a closet. And we are the only hospital in the Valley who's doing ERCPs. We're getting ready to start up that. We have a new GI program that we started last year. So we now have 2 full-time GI specialists, Dr. Cohen, Dr. McDonald, both from Seattle. And so we'll be getting referrals from all over the state because everybody's looking for somebody who can do ERCPs. The problem that we have is at our current facility, all of our patient rooms are doubles. So we have a demographic challenge. We are building a new hospital, which will double in size. So we just broke ground on it in the end of November for a 103,000 square feet new facility. $112 million, and we put in about $25 million of our own money, and then USDA is putting in $80 million in direct loans. So if anybody's wanting to build a new hospital, I can help you. So this is my second one that I've done. But we've been growing like crazy in Prosser. I think I'm the envy up here in that we've averaged 20% growth over the last few years. And this year we've just finished up with 11% margin. And cash we're at 160 days. If we didn't spend it all on the CIP for the beginning of the new facility, we would have about 190 days. And we've done that through physician growth and employee engagement.
Thank you. I'm Matt Miner. I'm the CFO of Columbia County Health System down in Dayton, Washington. We're also a critical access hospital. We have 2 RHCs, one in Waitsburg, one in Dayton, and then a freestanding clinic in Walla Walla, actually in partnership with the university there. We're about 28 million net revenue a year. We have no babies delivered on purpose and no surgeries done on purpose, but sometimes in the ER these things happen. We are a very small district that is very community focused. In the last session that kind of spoke a lot to me about the things that we can do and the things that we are doing. We have a transportation program and some of the other things we talked about. We started a dental clinic in our RHC this last 2021 actually. So these are the kind of things that we're trying in our community. And if I keep talking, I won't have anything to say during the actual questions. So.
Good morning. Can you hear me? I'm Krista Touros, and I work for Peace Health, and we have hospitals and clinics in a 3-state area of Oregon, Washington, and Alaska. My market is Washington and Alaska, and for close to 2 years, just coming off of at the end of October, I was also Assistant Vice President for Revenue Cycle Services, so I served all the communities in all the states. prior to being here in Washington, I served in Banner Health, where I was responsible for 13 hospital territory across 6 states. And prior to that, almost 20 years at Sutter Health. Finished out my last 4.5 years with the Oakland-Berkeley market. I love to say it is the same challenges as rural, but just with more zeros behind the numbers. Yeah, and so I ended up in the state of Washington because that CEO I supported my last 4.5 years at Sutter is the CEO I support again today at Peace Health. So I knew from a mission place this was a good place for me. And FYI, the weather's freaking awesome in Washington.
So we're all well aware of the financial challenges, apparently with the exception of David, current state, and losses that are taking place and closures across the nation. So let's talk a little bit about financial sustainability. I know right now it's a top priority in our organization, and so just curious on what your top revenue cycle initiatives and growth strategies that you've either recently implemented or that are currently under review for your organization.
So our priority for the last several years has been in employee engagement and physician engagement, as well as physician recruitment. So we've doubled our staff over the last medical staff over the last 5 years. We have over 50 on staff now. And our employee engagement scores, employee satisfaction just came in at 91%. Our physician engagement actually dropped to 85%. And so we spent a lot of time on culture. And I learned many years ago from a hospital in Colorado, Parkview, who made a strategic decision to focus on quality as their driver. And they had 20% of the market in a 500,000 PSA area, and 25 years later, they had 80% of the market. And they had some of the highest quality scores in the country. And it really drives home for us that it's all about the people. We do events constantly year-round. We're constantly serving meals to our employees. We wash their cars. Hospital week is insane. We have a cornhole tournament. And but some of our top revenue cycles, TrueBridge, we actually engage with them and are going live with them. And when we made that decision, it was because our growth. We just couldn't keep up in the billing office finding staff. And our goal when we went into that wasn't to find the one who could do it the cheapest. It was to find the one who would be the best value partner for us. And that's my mantra, no matter what partner we're looking at, for whether it's coding assistance, it's helping us, like I said, with billing or facilities or whatever. It's who brings the best value to us, right? We're doing a CDI to focus on physician productivity by improving their documentation and not trying to teach them how to code. I don't know how many people here have spent a lot of their career trying to teach a physician how to code. It doesn't work. And so instead, we're implementing a new CDI program. So we're looking for a partner who can help us design the CDI program, not do it, help us figure out what works, right? What should we do? And then really just changing our whole rev cycle. The director's position is changing. We're not eliminating it. We're actually, think of all the things that a revenue cycle director does. 80% of the time he spends doing, or 90% of the time they spend doing billing supervisor. And the other 10 to 20% they spend doing contracts and compliance and process improvement. And I think there's value in making that their job, because he won't have all those people to manage. So that really is our biggest ones.
I'd echo the same thing you started with, David, is a real focus on culture. And, we've heard so many things that just become cliche after a while, but really breaking down those silos and making sure that our departments are talking to each other and understanding that we're all, trying to row in the same direction. We're all trying to do what's best for our patients. And so rather than fight over resources, and that kind of thing, to be aware of, what your fellow department heads need to be full functioning for these same patients that you're trying to treat. So communication has been huge in the last few years of finding ways to bring those mid-level managers into every conversation and just get them talking together. One thing that we did that we take for granted that they understand what being a critical access hospital and being a public hospital district means, but there's some complexities to it that nobody ever sits down and talks to them about. You'll go like 5 years and then you've had some turnover in your mid-level management and even your floor staff, and they don't understand that the realities of our financial situation are not the same realities of a not-for-profit or a for-profit even hospital. It's very different. And so what we can say yes to and what we can't say yes to are very different, and they need to understand those constraints so that they know what we can do. So that's been a huge thing. We just finished our conversion from skilled nursing to an assisted living facility. We've got that open here in the last 3 weeks, honestly, and this was 8 years of due diligence, of trying to find a good partner to work with on the buildings, all that to really to make this right for our community, right? Because so few people actually need skilled nursing in their lives, but so many people need assisted living, and it's just a better place to have for our community, in addition to being much less of a cost drain. So, finding ways to use those resources effectively for the community has been our mission. So.
Well, unlike my friend David, we're having a significant financial downturn. We're on year 2 of financial downturn. And so our situation has become significant enough we know the reasons why, that we've now given it a name. Our initiatives have a name now. So from an enterprise level, we have mission sustainability imperatives. Never losing sight of the need to focus on long-term, we need very dramatic, immediate, short-term stabilization of our enterprise. So we are blessed to be led by an incredible system leadership team that rolls up their sleeves and is right at the elbow with us. We meet weekly. Our mission sustainability is focused on not broad, but going very deep in very specific focused arenas. That looks different for each network. In Oregon, their mission sustainability imperative is to hire 300 nurses by the end of June. That's their biggest challenge. In our Columbia network, theirs is length of stay. They haven't had as many successes with recent length of stay initiatives. And in my network, the focus is on regaining and growing surgical growth. That's a big one. We just invested in adding 2 more operating rooms, one of which is a hybrid. And our imperative isn't as simple as, just grow volume, grow your way out of the problem. We start every day lately, and on average at over 95% occupancy. So what happens? The ED most mornings have on average 5 to 10 patients waiting to be tucked in bed. So when you think about surgical volumes, particularly for hospitals inpatient, if you already can't bed your patients that showed up in the ED in the middle of the night, what happens to your surgery schedule the next morning? So that's really why our main imperative right now and our mission sustainability is focused on the surgical. It doesn't mean we don't still stay with all of the good things that are normal for managing finance, but we are very driven and focused right now by network on what the key imperatives are that'll move the needle for us.
Great, thank you. And for me at Mid-Valley Hospital, similar to what all of them are doing as well, we have also initiated a couple of strengths, specifically in our revenue cycle department. And as we've heard throughout the last couple of days, denial management is a very frustrating process, and trying to understand the varying denials with each payer. And so we actually hired a revenue cycle analyst. Of course, we're a lot smaller team. And so I meet with them weekly, her and the director of revenue cycle, and we just start kind of plugging away at the top denials, and it gives me the opportunity to really understand what they're going through. And because I also wear the payer contracting hat, it's given me the opportunity to be able to reach out to maybe contacts I have at the payer level to see if they could provide any immediate assistance, because sometimes it can be very challenging to get a fairly quick answer from the payers when you reach out to them. We've also embedded our director of revenue cycle and HIM manager to attend, mandatory that they attend daily rounds, clinical rounds. And we've seen a huge improvement here, and also not just from being able to provide, that coding, documentation, education to provide our hospitalists or surgeons that are right there with the rounding team, but it was very interesting to learn that some of our staff didn't even know our providers, and so they've built that relationship by attending team rounds, and so that's been a great opportunity there from both sides. And we're also we've partnered with a couple of companies to look at some pricing strategy analysis, and so we're working on that right now, that initiative right now. And we've seen a shift in our agency contracts where we can actually go to the table, and we're seeing pretty significant negotiations there and being able to lower that cost, and so that's helped. But we also are trying to recruit heavily to the area, which can be a challenge in a rural setting, as we all know, to get people to move their families to a rural area. But that is the main focus right now, so we can reduce that agency cost. So on the cost side, have any of you had to reduce service lines, or what's your cost reduction philosophy as far as that goes for your facility, or have you had to do a mass reduction in FTEs?
So I'll take that one on first. So simultaneously with the other work I mentioned, we are actually doing a lot of work around service line assessment. And it's not just service line overall performance, but in the focus, staying focused and getting deep, we're down to looking at literally procedure level codes, et cetera, and assessing, can we continue to be all things for all people, if you will, right? Where do we capitalize on where we have strengths? How do we grow those areas that are not good performers in the health system? We're also doing a full assessment of our medical group portfolio. We are well entrenched in our shared services center, and everybody's got skin in the game on this turnaround. And the shared service center is a model that we target a certain percentage of revenues as the overall operating cost. That's been lowered dramatically. So to put it in perspective, right, they have literally maybe a month to harvest $145 million savings just out of corporate center. So everyone is feeling this, but again, it's a very focused, data-driven exercise on getting some cost reduction. It's not the typical, yanking on levers just automatically give me so much head count, which I will tell you as a CFO makes me lose my mind. It doesn't mean I haven't inherited places before where turnaround was going to require that. When you are in a situation where you're looking at FTE reductions, a couple of things have happened. You either took your eye off the ball to get yourself there, or you've got service lines that probably need to be lobbed off, right? So think about health services as an octopus. Sometimes you got to lob off one of those legs. It's not easy decisions to make, but when you think about FTEs in an approach of just, hey, if I can get 100 head count out of here, you're already failing as a leader. First off, it's incredibly insulting to the people who do the work. You're assuming people are twiddling their thumbs, and now who's going to absorb the work? The work doesn't just go away. And I think the other thing that gets missed so often in a leap to FTE reductions as your cost salvation, the people who are left behind. Their coworkers are family to them. They have relationships. So you create a lot of morale damage in your organization. All your culture work is for naught when that continues to be the old school lever that you want to pull to right your situation. So it doesn't mean that we won't have some of that, but we're looking at it as not all these duties this person did now shift to someone else. It's what do we need to not be doing today that we've done all along. And in that respect, will there be less headcount in the organization? There will be, but it will be leaner and it will look different and it will include process improvement and continued focus on process improvement, not just an assumption there's someone there to pick up the baton.
Pass. No, just kidding. No, we're actually kind of in an opposite situation where as this senior leadership team kind of came together over the last 5 years, we realized that previous administrations at our hospital had been on that lean kick, on that efficiency and that kind of thing. And what happened is a lot of stuff just wasn't getting done. So we've actually put in a layer of mid-level managers that wasn't there before. But what it's doing is it's making sure that the people that are caring for patients, and they're not worried about administrating their department. They're more focused and able to do their jobs. Being a critical access hospital that is so heavily Medicare utilized, I don't think I said, but we're between 50 and 60% at any given point Medicare utilized, and then another 14% Medicaid. It makes you can cut costs and wind up saving very little net of reimbursement, but doing so much damage to the organization. So you always have to think about what are we really gaining operationally by cutting, an FTE or any other cost, for a department. There's a real world, that's something we don't have for them anymore, and then Medicare's just going to get their portion of that savings. And being more efficient is always better, but you have to consider the net cost of these things. So that's our strategy when it comes to cost.
I want to add one more little tidbit around that because it's so spot on. So, we have our local level too, work that we have to do, right? So we have our own level of more, we call it our monthly operations review, that is part of sustainability. But when we look at a department that's struggling, I have leaders who know their payer mix in their departments. I also have leaders who still assume that their drop in commercial mix in their departments is directly related to pricing. So how do we partner together to either prove or disprove some of those myths? When we do monthly operations reviews, we have very engaged directors. PT I'm going to use as a great example. Our PT director has been convinced since long before I arrived that our problem is pricing for his massive leakage on commercial share. When you really think about the service, though, and peel the layers back, one of my first questions to him, how long does it take to get an appointment in physical therapy if you're a new patient, right? As finance people, I encourage you to know these things, by the way, because guess what I found out? It's an 8-week wait. If you have commercial coverage and you're in a market with a lot of freestanding alternatives for physical therapy and you're in pain, you're not waiting 8 weeks for a new patient appointment. So I challenged him that could be part of why he's seeing his leakage. As we dove deeper, what else did we learn? What's your no-show rate? How many of y'all know your no-show rates in some of your outpatient services? Pardon me. In the case of physical therapy, it was 15%, right? So 15%. So we dove into that a little bit deeper. The actual physical therapist could predict and knew which patients weren't going to show. So we have schedule gaps. We have holes and we have 8-week waits. How can we engage the physical therapist now to be part of the scheduling, not just the patient access person and scheduler that manage it for PT? Now we have the physical therapist part of it, and we're looking at the actual patient name load. And guess what? You've been a no-show for your last 4 appointments. We're booking you but we're also booking someone on top of you, right? And if you happen to show up for this appointment, you know in advance and it's reaffirmed when you arrive, you will have a little bit more of a wait because we're going to go ahead and see that other new patient that came in or the other patients you regularly show. So it's never as simple as the FTEs. It's oftentimes, when I say improvement, it's not necessarily that everything has to be a scripted Kaizen event to move forward, but really get out there with your operators as finance people and ask the questions about the operations. And it does get you out of the weeds of your numbers a little bit, but you learn and you serve your people a whole lot better when you can add value and ask those probing questions you would ask, either having experienced as a patient or just really understanding the whole book of business, the whole part of the service line and the key drivers. There are no simple solutions, so you've got to learn where are those operations pinch points and how do we get improvement by focusing on that quickly. We've had some dramatic turnaround. I was mortified. I've been in this business 25 years. I had a physical therapy operation that was losing $332 a visit. How do you do that in PT, right? So, when I say go deep, right, have your focus, know where your areas are that are struggling the most, but then really go deep. Put your waders on and physically go to their space and follow them around in shadow if you need to. But ask those questions from that inquisitive, really seeking to understand before you're making big financial decisions.
Of course, we haven't done staffing cuts in many, many years. But what we have done, for example, over the last 4 years, is we've seen our productivity increase by over 125%. So while we've been growing 114%, our FTEs only grew 44%. All right, so that's net revenue too, not gross. And so we've been very conscious of growing and using our capacity, right? We spend a lot of time on engagement. We spend a lot of time on education, a lot of funds on education. We spend over $1,000 a year per employee per year on engagement-related activities. We've recently added all of our staff to our bonus plan. So now all the staff can get a portion of it if we hit our limb. And our limb is from Studer, for many of you who understand that. But our bonus plan is driven by 30% patient satisfaction, 20% employee engagement, 20% physician engagement, 10% quality, 10% service, and only 10% finance. Because the top number is the one that helps with everything, right? If you don't have good employees, you don't have great, good physicians, you're not going to have good patient satisfaction, and therefore you're not going to have good quality outcomes. They're not going to come to your hospital, so you're not going to have good financials. So, it all ripples. We actually went live with Premier's productivity platform to help us give us benchmarks and more in-time data. So we went live with UKG Kronos 2 years ago. We're just now going live with the Premier Productivity, replace what we're doing in-house, because our goal is don't add without first making sure that we're doing everything right. I'm going to give an example of where we added, though, and we saved. I had EVS staff, and they were 2 shifts during Monday through Friday, and 1 shift on Saturday and Sunday, and the night shift all the time, and then the evening shift on the weekends was on call. Well, I have a 3-hour callback at overtime, guaranteed. They're getting called back constantly. I actually increased our staffing, went to 24/7, and my costs went down. Right? My turnover went down. And we have very low turnover overall because we have great bennies. And we also raised the pay of all of our employees. Right? So very aggressively. So we're at the median or higher with all of our employee wages. And so we were able to control our costs by retaining our employees and not having to recruit employees. So.
I don't know about y'all, I want to be David when I grow up.
So as facilities continue to be challenged with labor shortages, what new and innovative approaches have you successfully implemented in regard to recruitment and retention?
I'll be real short on this one. We have not engaged in bonuses other than on a couple of key hard to fill. It's not worked. You offer them $10,000 and you can't find the people who have the aptitude and the attitude that you want in your facility, regardless of whether they have the experience. All right, and they're committed to our mission and our vision. All right, so if they don't have, I tell my staff, my leaders, when they're interviewing somebody, look at aptitude and attitude, and then experience. If they don't have the first two, I don't care about the third, because I can teach people, give people experience, but I can't give them attitude, right? And so that's first and foremost. I did want to make a comment about your critical access. So when you're doing staff cuts in a critical access hospital, not all dollars are equal. All right, so if you do staff cuts in a CAW, it has to be strategic, because you cut $1 in med surg, you get 10 cents back, right? Maybe you cut $1 in maybe OR, and you might get 60 cents back. So.
Yeah, that's a great point, and I think something that might get lost a little bit sometimes is translating the cost report to the actual operations of the facility. And this kind of a counterpoint to that is that, you know, we say things like, we definitely want our nurses to float from acute care over to ER when they're needed. We do that. We definitely don't want travelers in the ER. Well, if you have nurses that don't want to work the ER and you're forcing them to, you're going to lose your nurses. And so sometimes you do have to make a decision that isn't in the best interest of reimbursement, because your people just won't tolerate anything else. And so that's not a direct answer to that
I always
question,
I always told my ER nurses when they were in their downtime, to step over to med surg and do their notes over there, right? And yeah, float your time, right? Because not all areas are equal.
Right.
Yeah.
Right. So one of the things that we've done with the staffing issue is we actually engaged our marketing director to become a white glove recruiter, and we gave him a bonus structure behind that. His bonus is considerably less than what we pay outsourced recruiters. You know, so it was a little difficult to find the right balance there, obviously, because you're going to have hurt feelings with other people that aren't bonused for bringing people in, although we do have referral bonuses, but this was beyond that. But it really worked. You know, we were at a point where he brought in, I want to say like 8 nurses within as many months. And, you know, we weren't paying recruiting agencies, we weren't paying travelers for those things, so it worked out pretty well. Another thing is just the housing situation, and we've tried various things on that. You know, one thing we did was put in 2 RV pads right on campus, and that's actually helped in PT because, you know, we've historically always had travelers in our PT, and honestly, that's not as fiscally prohibitive as traveling nurses. Traveling PTs really aren't that much more expensive, but I digress. Anyway, a lot of them, they're travelers and they have RVs and they want to, you know, just stay close to campus, and so that's actually worked out very well for us. It's just having that ability for them there. So,
Okay, so again, not like my wonderful friends up here. We have significant labor shortages and challenges. Add to that, I have 2 hospitals on islands, and one is in Alaska. Who wants to go live in Alaska? Some of y'all might want to, but you know what? A lot of laborers don't, not people who are your, you know, $18, $24 an hour wage earners. We have significant shortages in lab technicians, clinical lab scientists. We have significant shortages in nursing that I think many people suffer from. And we're trying to get very creative now with our recruiting strategies. So in Ketchikan, for example, we are going forward with a pilot on an international recruiting model. to sponsor nurses, bring nurses over, 3-year commitment. There's a couple of companies that do this and do this very well. We are also in Alaska investing in more housing alternatives for our caregivers. And because Alaska, Ketchikan in particular, is a destination location for a lot of folks, we employ people intentionally as temporary workers that come and live on island for several months. We have a taxable stipend we provide that compensates for travel, et cetera. And lodging and rental cars, so forth. And some of those temp laborers will stay as long as 11 or 12 months of a 12-month year. But they're happy there and they love it there. So that's a very different strategy than what I need in my other markets. Over on San Juan Island, that's a very tiny 10-bed critical access hospital. And we have challenges recruiting even patient access. You can't exactly build housing on islands. Don't know if y'all know, there's not a lot of extra space on them, and you can only go up so high, right? So we watch the real estate market very closely. We bought a condo last year. What was happening was we were recruiting people, and they were excited to come work for us, and right before they start, we lose them. Why? They can't find anywhere to live. So we had an amazing nurse manager candidate for the island, and almost lost this candidate because absolutely impossible for him to find affordable living on the island. Well, we can rent our condo out at fair market value, and he has bought himself unlimited time on a month-to-month lease arrangement with us for all the time he needs to find housing. The other thing that we've done for that particular island is implement a taxable ferry stipend. I say taxable because it's a fringe benefit. We don't offer it to everyone, but we gross it up, and we've done the homework on it. And people can choose to drive on the ferry or walk on the ferry, but we reimburse them through their paychecks every pay period. As again, thinking from an administrative burden, right? I don't want I want taxable's great. I don't need all their ferry receipts, right? So, and you can't actually pay tax-free commuting miles anyway. So, but they're happy. They get extra money in their paycheck, and most of them choose to walk on the ferry because it's a lot cheaper than driving on the ferry. So now they kind of are tickled pink. They have a little bit of a pickup over the folks who drive. In my Bellingham market, our big labor shortage area, in addition to nursing, is also surge techs. I don't know about any of y'all. We're having a terrible time recruiting and retaining surge techs. Again, beautiful space we live in, but it's expensive. Whatcom County is very expensive to live, and so we're doing a twofold approach here. First off, we really need these folks to stay. Bellingham has a technical college. Don't know if y'all know, right? And they have a surge tech program. So we've now gone out, sent some of our best leaders from the OR, gone out, partnered with the technical college, offered scholarships to people in the school. These folks have jobs waiting for them, and our goal is their last class had 7 people. We want all 7 of them. So getting to know them ahead of time while they're in their programs and making sure they know they want to stay with us. Sorry, I forgot my water jug, my friend. And looking at housing alternatives as well in our Bellingham market. It's not about the free housing for our caregivers, but it's about affordable housing and doing that within the confines in a compliant manner, but in a way, thank you, but in a way that lets us be part of the solution. It is painful to get good talent and have them not show up there that week before they start, and you're back to ground zero. And now, how much does that cost you to continue to backfill because you have to start all over again? So just repurposing the dollars to invest more in those caregivers. And retain, retention is always a focused effort, but we now have a program as well. We're going to start going out to high schools and start getting high school kids excited about healthcare, whether it's clinical or non-clinical, and work on our internal policies. Some of our own problems are self-inflicted, right? So we have this little self-inflicted injury where we don't let anybody volunteer unless they're over the age of 18. We did that to ourselves. But how fun for a high school student to get to come and shadow, especially in summer, right? And get that level of excitement brewing while they're still in high school making college choices and career choices. So we're hard at work getting some of our policies revamped and revised to support some of these other strategies.
And for us, we've done a lot in regard to interviewing and recruitment as well. Living in a small community, it's difficult to get people. It takes a minute to get people to Omak, Washington. You don't just get there via flight. Then there's a 3 or 4 hour drive. And so what we've done is because a lot of our, especially our management and executive team positions typically come from out of state, out of area. And so what we started doing was we hold one very, it's really not structured. We don't ask a lot of technical questions. It's more get to know them get to know us, and see if it's going to be a fit and if they're going to actually enjoy moving to a rural community. Because it can be a big change for a lot of people. So we hold that call, and if we basically jump on it as soon as possible, because people are getting offers all over the place, and if you don't move fast, you're going to lose them. And we've learned that the hard way. And so we will, if the interview goes well via Teams, we will actually place a contingency offer for them coming on site. And when they come on site, we really hone in on our culture at the hospital. Every executive team member is there to meet them. And we also really push the community so that they have a clear understanding of the benefits of living in a rural community, and then also maybe what isn't like readily right there, how far you have to drive to do certain things, so they understand. Because it costs a lot of money to get somebody there, and we don't want them to come and be there a month and then turn around and leave. The other thing we do is we partner with the real estate agents locally, and we carve an hour out of their stay while they're on site so that the real estate agent can take them around the community, because who knows better than the real estate agents. And they drive them around and show them the various neighborhoods, the school districts, and really try to, again, sell the community. And we had an interesting situation back in, I think it was May. It was a scary time, so I've kind of blocked it out. May of last year, we had 3 of our 5 board members resign, and that created a lot of anxiety within our staff. Our morale dipped very quickly. And there was actually a point where there was only 2 members, myself and our director of HR, that was left on the executive team. And so we had to build our team very quickly. Our CEO had just retired. We were actively recruiting for a CEO. He joined our team in October, and he was like, we have got to get this executive team and our management team built. We had, I think, 9 positions open at the time, and we successfully have filled all of them at this point with the exception of 1. And so I think that our bringing them in and having that mindset that we want to get to know you and we want you to be a member of our family, not only within the organization, but also the community. The feedback that we've received from our candidates, it's been very successful, so that's been great. We also purchased a residence very close to the hospital that came up for sale because, again, as everybody here is having the housing issues. And I always tease my HR director that he should get his real estate license because he knows every landlord in town, which is helpful in a small community. But we have great relationships with them, and so immediately when somebody signs to join our team, we start looking for housing for them. We want to help them. We don't want that to all just fall on them. So we determine what their family size is, if they have any pets, and then we just go out and market for them and try to land them a place as soon as possible. So that's helpful. Where are we on time? Because I don't know if I was supposed to keep track of that, or Jesse's going to yell at me, or... We got about 15 minutes. Oh, 50. Oh, okay. So for Q&A?
Wait, no, sorry, I got that wrong. We have
An
an hour.
hour?
We can do,
Oh, okay. Okay, great.
okay.
It's like, you have a question?
I have a question.
Oh, okay.
Yeah. I'm loud, but maybe people want like.
I mean, we have more questions up here. I just... Didn't realize we had so much time left.
But you guys were just talking about a lot of important recruiting challenges associated with housing, and like you said, that housing need is totally different for each person, right? So you guys talked about people with RVs, people that needed housing with whole families and pets, and so all those things are fantastic. But like, as you're going through the recruiting process, right, that involves a whole bunch of questions you're not supposed to ask. Are you married? Do you have kids? Those kinds of questions are kind of prohibited in the interview process. So how do you navigate that? Has that been a challenge? Have you guys given thought to it?
Yeah, that's a really great question, and I will tell you that you don't do that during your recruiting process until you've issued an offer letter to someone. It's a two-way dialogue, right? So when you hire someone, you shouldn't be no contact with them again until new employee orientation, right? So, for example, my nursing teams, we're doing welcome baskets, right? We hire a new nurse, guess what? They get a little note card from the CNO, they get a little welcome basket with some area-specific goods in it, sent directly to their homes. This is after they've accepted an offer. So, post-offer, right? So you continue to make sure that new hire knows how excited you are for them to join. You touch base with them and ask them, how's your search going for housing, right? As the hiring, no, not during the recruiting process. Absolutely not. First off, I can't afford to house we have over 15,000 employees. I can't house 15,000 employees. So we're not soliciting in that manner. It's more as the hiring director. Stay connected with your new recruit. Don't wait for let's get real, it's healthcare, right? Who can onboard in less than about 6 weeks at a minimum, right? You accept a new job in healthcare, should you not hear from anybody for 6 weeks? How many people start getting antsy going, yeah, right? So make that personal connection, make it where by the time they arrive, it already feels like a home in your organization, but just as importantly, you're knowing and understanding any struggles they're facing if they're someone that has to relocate. And so it's more that approach, right? So, we probably house on average about 20 people in Ketchikan on the regular. We're housing right now one on Peace Island, at the Peace Island facility. We have a need for more personnel. Housing's a challenge. We too are looking at, maybe we rent some RVs ourselves and put them at the HEP house down by the water line. Because what I don't want to do is have people and their families be so married to the hospital that my big empty parking lot becomes the RV space for new folks. Them and their families, they need to get away from the hospital at the end of their shift. But we could rent RVs. It works for some people. So it's literally that level of creativity we're trying to get to people. But it's staying connected to your new hire throughout the onboarding process. Just because it might be talent acquisition's job or HR's job or whatever to go all through that shigamashu of stuff that happens once you accept an offer, you as a leader should still be making that regular. I advise at a minimum, if you're 2 months to onboard someone, then at least every couple of weeks, just reach out. Right? We're all pretty good with text messages, so are our new employees. Just reach out. Hey, how's it going? Just build that relationship. I tell you, it makes an incredible difference in your culture bringing someone in new because they already have a sense of who you are as their leader and they already feel welcome and embraced. So I don't know how much that helps with that, but yeah, no, definitely not crossing any of those HR lines.
Yeah, and I would have to agree with that. That's 100% what we've done. And we've also started just staying in constant contact. So once somebody signs, it's just the feeling of, we're so excited to get you here. Are you experiencing any barriers? How can we help? What tools can we provide? And before you know it, they're telling you the whole life story. Like, you don't even have to ask a question. They're like, I've got 4 dogs, 3 cats. This is what I need. And so more often it's just that relationship building, and it all just kind of comes to fruition.
And it's funny you mentioned the animals, so the same nurse manager, right? So we came up with this creative solution, and we're running him and his family the condo, and it was probably about 2 weeks before his start date, and it was like, yeah, oh, by the way, I have a dog. So, you know, I am a CFO. I did tell my CEO I want no smoking, I want no pets, I want no writing these lease agreements. But you know what? That's self-imposed. So we course corrected, we made an exception, so the family pet could come along. It's situation by situation, and whether you own your real estate or you're leasing, we're constantly looking for open housing that we're snatching up and doing our own leases on to have a landing pad. It's pretty low risk, because you never know when you need a locum, but you're always going to need one at some point. You never know when you need contract labor, but it happens. We'll never get to a state of zero contract labor, and you're on the hook for that anyway. So if you already rent housing, you have a landing pad in that respect too.
Most of the hospitals, every hospital I've ever been in, when we're interviewing, part of that discussion has always been about, is this community a good fit for you? And are there any challenges? And then they volunteer almost 100% of the time, because then you can help them answer the questions that they have related. Is this a good fit for the family, right? So whenever I bring, for example, a leader on board, or to come in and interview, you know, I ask them, is there anybody else you'd like to bring with you? Right? Whether it's a child, whether it's a parent, whether it's a significant other. Because if it doesn't work for the family, it's not going to work for the individual, right? So we don't have a robust housing program, because we have the same problem everybody else has. There are no houses, but we're ultimately trying to make sure that it's a good fit and that they'll stay. I remember years ago I interviewed in Marathon, Florida. I don't know if anybody knows where that is. It's the first island up from Key West. All right, and talking about fit, and I'm interviewing and I'm talking to the CNO, and he tells me that there are they get 2 kinds of employees: those that stay 2 years or less, and those that never leave. And it came down to about the island life. Do you enjoy the island life? Because you're isolated. I mean, it's a 2-hour drive up the highway, thankfully, to even get back to mainland. And at the end of it, when I went home, I'm like, they offered me the job. I was like, I can't do it, right? Because everything that I wanted to do had nothing to do with what was on the island. Right? I couldn't play golf. I couldn't go biking. Because it was all crowded island and all that. And it was like, wow. So it wasn't a good fit, even though it was a great job. But it wasn't a good fit.
And I'd echo what everybody else said, is that it's not necessarily about asking people about their situation because they know their situation. It's about explaining what the community is like, what the community does offer, and where the challenges are in it, you know. And I'll ask in the first interview, what do you know about the community? And then by the second interview, they have done some research. So I think that's it, is you can always put out the information, you're just not asking them the protected questions.
Yeah.
So.
We always make sure that when somebody comes on site for an interview, that they have an extra day. I always make sure they have at least one full day that they can spend exploring the community that's not tied up in the visits, right? Because generally if they have somebody with them while they're interviewing, that person's out gallivanting around the community trying to figure out what's going on, and we can hook them up with somebody else in the community, a realtor and so forth, to help guide them. But ultimately, it comes down to, a lot of times it comes down to feel. Do I like what I see? Do I like how it feels, right? And we do round robin interview process where if you're coming on and doing an interview and you're a leader, for example, you're going to have group interviews with You're going to have individual interview with your administrative officer, whoever your person is on the senior team. And then you're going to have a group interview, maybe 2 with different groups of leaders. You're going to have a group interview with the folks that you're going to actually be supervising. If you're interacting heavily with physicians, you're going to have physician group interviews, because everybody sees different things in people, all right? I tell people that I'm really good at identifying aptitude and attitude and, right, the ability for people, right? But that my issue, my weakness is seeing behind the mask, all right? What you show me is what I think you are. And there are other people who are really good. My wife is awesome at it. Right, you talk to her for 10 minutes, she knows your life story. And, but she's really good at reading people. And I mean, and that's some people's skill sets. And so when you do that group thing, people get a real sense of what the culture really is in your organization and whether or not it's going to be a fit organizationally before it's even a fit community.
I just want to maybe see if I can piggyback on all this discussion, because I know with the critical access areas is attracting and trying to recruit physicians and trying to put the right contract in place. I mean, those are the ones that are harder to get than anyone else, because you may have an aging physician group that's ready to go, but it's hard to find those younger physicians who want to live in a smaller town. Look at areas that this is, do I want to grow my family? But then they come there, get the experience, then they're gone. So, I mean, how do you get through that physician challenge more than anything else, especially in the rural communities?
So for us, somebody knock on wood, we actually, that is an area that we have not had an issue in, is our medical staff. We have a great med staff team that's really invested in the community. We currently just have one open position, and it's in behavioral health, and it's been a challenge to fill that role. So, but I do know what you're talking about. We've actually had physicians drive, this was years ago, drive into OMAC with their wife, and their wife was like, turn around and get me out of here. There is not a mall. And so it can be a challenge, yeah. Or, you know, they want to place their kids in gymnastics, or, you know, they're big into music, and so they want a big music program. And, you know, that stuff just doesn't exist in OMAC. I mean, they're to a very, you know, low level, but not maybe to the level that they want or what they're used to from where they're coming from. And so it is a challenge. Luckily right now, though, we haven't had the provider shortage that some places do have.
We've done well. We do have our challenges with physician recruitment. We're fortunate in that we're only 25 minutes away from the Tri-Cities. So, you know, a very, you know, energetic, robust, young community, you know, 300,000. So there is housing over there. There's good schools. There's the mall. There's there's lots of stuff to do in the Columbia River. So that's a positive. Some folks live in the Prosser. Probably only about half of our staff actually live in Prosser, and the other half live from anywhere between Yakima and the Tri-Cities. So that has helped. I think the biggest thing that we've struggled with is we've done a really great job of identifying great clinicians, but not always great fits, right? And so sometimes you jump at it, you know, and a year down the line, you realize, yeah, it's not really a great fit for either one. And you have to have the willingness to walk away from it if it's not working.
Yeah, I'd say that same thing, as we found, you know, people that were great clinicians and just not a good fit for our organization, or they realize a year on that this was not what they wanted. You know, we'll invest into people, and sometimes they're in an earlier portion of their career, and then they'll see what this career actually looks like and decide, maybe I don't want to do this. Right. You know, and then our, you know, physician recruitment challenges are different for every location of service, of course. You know, in the ER, it's a lot easier to have somebody that just works like one weekend a month, right? And so anybody can spend a weekend a month in Dayton. it's a nice place. They don't get to sleep much, but they're there, and so those kind of things make it easier because then they can just go home to whatever home is and be with their family for the rest of the month. But for our actual in our RHCs, our providers there, it is tough to find that correct fit with somebody who really does fit with the community, because obviously you can have the best clinician in the world, but if they don't get along with your patients, they're not going to build a career here. So that's tough.
So my very first CFO job was in this beautiful community in California called Lakeport. We had the largest natural lake in the state of California and ESPN bass fishing tournaments. So physician recruiting became creative, like posting in Field and Stream. So really tapping into highlighting your community and tapping into people that's what matters to them. In our current situation, if you're not currently experiencing challenges with physician recruiting and retention, you will. If you're paying attention to data, and we are facing an incredible aging out of medical providers. You hear about it with CEOs, you hear about it with CFOs, you heard about, but medical providers, massive aging out. And we heard from our speaker earlier this morning about burnout, right? So there are a lot less people entering the workforce, more people exiting, less entering, and that's true of physicians as well. So I think that strategies have to capitalize on some of what's in it. And you also have to recognize you might only have a provider for 3 or 4 years, and that has to get okay for us. There are incredible programs for student debt loan forgiveness, for people coming out of medical school and going and serving in rural communities. Will they stay forever? No, but if that's going to be what my eye's on and my strategy, I'm going to hurt and not sleep well. I've got to get okay with helping being that next step in a young professional's career as they're developing, and then hope that they, you hope they just fall in love and stay, right? Or even better, maybe they'll fall in love with someone in the community and they're forced to stay. But the reality is, just like our workforce, we have a very kind of gypsy vibe workforce for the most part, right? And people want to move around. They want to go experience life. Work is not 100% it, and our communities might not be 100% it. So I think it's important to accept and understand what is your sell for a short term. You can always hope for that long term, but what is your sell for a short term? Understand your government-funded programs, especially at the federal level for small communities. And, is it easier to retain a physician in a big city? I would actually challenge folks on that, right? I had Oakland, Berkeley market. I was fortunate my cardiologists were Stanford. Most of them do stay, by the way, if they're working at Stanford. But I think that challenge is one of the headwinds facing all of us in the next five-ish years. You don't need it now. You should work on a strategy now because it's coming. I put data together about physician age across all of my markets, not just where I serve, but other entities too. I want to understand the physician demographic. And I'm telling you, in Washington, we've got some challenges headed our way. My philosophy, my belief, fill your needs now for today. Hope you win over the heart and the community wins over the heart of people who come to your communities and they do want to stay forever. But many of us also have nomad communities. It is what it is. So how do we serve the population the best for now, but never lose sight of what our long-term strategies are? And our long-term strategy might be that we can expect we're going to turn physicians over on a 3 to 4 year cycle, or however long it takes for the federal government to forgive their loans. But hey, it works.
Want to thank you guys again for doing this and being available to us. I'll change gears a little bit. From a vendor perspective, that's my favorite question to ask whenever I have access to a CFO panel. I'm not talking about a magical service line or a magical technology that will solve all your problems, but what I am asking, would love to know from each of you is, what in 2023 are you looking for from vendors in terms of that relationship, that value add? What aspect of the interaction are you not getting now that you wish you could get from your revenue cycle business partners? Yeah, would love to hear that from you and know.
That's a terrific question. I'd love to take a first stab at that. You know, this labor shortage is not limited to clinical personnel, right? I think that this shortage of coders, for example, is across the nation. And I believe that there is new advanced technology, and vendor partners are, quite frankly, this is an incredible opportunity for vendor partners to differentiate themselves and bring forward. So autonomous coding is a great example. I can't keep employing 20% of my coders through contractors, because guess what? A place like Banner Health now, you can work anywhere in the country and be on their payroll, so you don't need to work through an agency. So my agencies can't fill my needs anymore. So I've got to think differently and stop relying on 100% humans for my coding. I need the advances in technology that can do a lot of the predictable, you know, et cetera, et cetera. Don't try not to use techie words. That'll really not be awesome here. But not my strength, just saying. But I think that the climate has changed, and I think where people were 5 years ago in even their thinking about their revenue cycle needs was still very much on how things have always worked. That with the headwinds in front of us, that's not going to be the case going forward. So what I would be looking for in partners is that value add. First off, the word partner, the value add. I like it when my partner's got some skin in the game. And a lot of people are not on that page. I have an opportunity to do a type of arrangement right now where I have a vendor who can fill a significant need. That's a lot of revenue being left on the table. And they gave me 3 scenarios of how I could structure an arrangement with them. And the third one is the most expensive, however, provides the labor to also do the work. So it's a turnkey solution, except for IT. And I hope there's no IT professionals in here, because I don't even get me started on that piece of the slowdown and the barrier to technology advancements. But honestly, that is where the big opportunity is right now. How do we take it to the next level and actually not need as robust not need 900 caregivers and revenue cycle services, be able to continue to repurpose and grow the ones that I have into the real intricate things that need to be touched. But how many things do we touch every day that technology could help us stop touching? That's what I'm looking for.
I'd like to offer kind of a little bit of a counterpoint to that. When it comes to my vendors, I don't want you pulling the humans out too soon, because one thing we found is I don't care how foolproof you think your new system is, it's not. And so when there's a problem, can I get a hold of a human? Can I get a hold of somebody who knows the system well enough that they can fix the problem? You know, and is it just going to be a patient service rep, or am I actually going to be able to speak to a subject matter expert that can identify where something went wrong? I have a vendor that I won't name that just for a year, it was like, oh no, that's weird, you know, and that's the response we get, or, you know, just constantly, just constantly like, you know, I've asked the team about this. Well, okay, why can't the team talk to me? Because clearly you're not explaining what the problem is well enough to them for them to understand to be able to fix it. So I think that's a huge thing is, you know, no matter how good your system is, there is some flaw, so how good is your customer service?
I would say if for me, the vendor, that they have to be visionary. If they're not envisioning what their future is going to be like in the next 5 years, because, yeah, with AI, if AI does what people think it can do, it's going to change our world, right? Even more so than the cell phone did. It can be amazing, and coding is a made for AI tool. I mean, it's all documentation, right? So, I mean, there is that. What really excites me about the AI is the ability that it could help with diagnosis for physicians, right? That it becomes, and it's not the diagnosis, it's a tool for diagnosis, right? I like to say that the greatest diagnostician that I've ever seen is on TV. His name was House, right? The guy was right? He was amazing on TV. But that's what where the power of AI can really transform, in that it can take all the symptoms and all the results and say, did you think about these things, right? Do you really need that MRI? Do you really need that CT? Because look, right? But from a vendor, I know we were looking at, and I talked about earlier about our CDI program, in that it'll improve our productivity, it'll reduce our denials, it'll increase our physician satisfaction, right? Because it drives them crazy being queried by medical records, right, by the coders 3, 5, 7, 10 times a day, right? And or then we get a denial from the insurance, right, because that's their first step, right? And then they challenge it. And so we can improve their documentation. So that's why we're focused on CDI. It's a preventive tool, right? But it'll actually pay for itself. But I know we need to do it in-house as much as we can. So.
Yeah, I just ditto what they say. I mean, the partnership thing for me, I don't think this is working at all. The partnership thing for me is key, because there's so many business partners out there that it can be a little bit overwhelming, a lot overwhelming. And so really finding that true partnership where you are going to have skin in the game, and like Matt alluded to, is, you know, post-implementation, just really, you know, having somebody that you can reach out to, because it isn't always as perfect as the demo looks. It never is, never will be. And so it becomes frustrating when you just kind of get thrown out there and you don't have the support that you felt like you were going to have initially. And so that's key for me as well. The autonomous coding, I just had a meeting with a company on that as well. We have a hybrid model. And so we have a couple coders in-house, but they're gradually, you know, fading, and you just can't find them anymore. And then we have global coding, but again, that, you know, the companies, you know, as Krista said, it's just, they're not having the staff either. So then you go, or excuse me, domestic, then you go global, and then you have the time difference thing. And so if we have, you know, a couple of large accounts out there that are on hold because of some reason, then, and we pose a question to them, then there's this big turnaround time because of, you know, the time difference. And so that can sometimes become a challenge as well that you have to kind of work through. So yeah.
Well, on behalf of all the vendors, I'd like to apologize for bombarding you guys. I know it happens, and it is overwhelming. I try not to do it.
We love our vendors, don't apologize.
Okay. I have a two-part question. Krista, you mentioned, you know, that a lot of the pain is self-inflicted, and that data and demographics are, you mentioned that, are really key. You know, housing, I think a lot of you have brought up, you know, the importance of having housing for staff that come into an area, and I think that it's going to be somewhat resolved because about 500,000 apartments came online last year, and another 500,000 are coming online this year. So I think a lot of the housing, at least in the metro areas, is going to be solved. That doesn't do anything for the islands or the remote areas like you've talked about. But knowing what housing is available, I think is important. And I wanted to ask you about that, just kind of the, what knowledge level is available to know what housing is available, right? Because that's not really part of healthcare, right? And then also, along the line of being like self-inflicted pain. I was on an airplane a couple years ago with a gentleman, and his wife was a nurse up in St. Joseph, Peace Health facility, and he said that the nursing shortage was largely self-inflicted because only nurses coming out with a 4.0 grade point average were hired. And I don't know if that's true. That's what the guy told me. But I wanted to ask you, like, how much do you think maybe having knowledge of the area and just general knowledge outside of healthcare, and then also you mentioned also going like to high school students and lowering the age, different things like that, keeps shortages from being self-inflicted. And then I have a second question, which is more critical access related. I saw a list come out in the last couple days from the National Association of Rural Hospitals, and they listed 631 rural hospitals across the nation that were likely or very likely to be closed because of financial stress. And there were a few here in Washington State. There were 78 in the state of Texas, for example. And then I think another statistic that goes with that is that staffing shortages, according to Revenue Cycle Intelligence, they said that they raised 258% from 2020 until now. So I want to know how much that impacts on the rural critical access hospital. So really two questions.
So on the nursing, and I'm glad you asked that question because it's another area where we've had to reshape thinking. Now, I don't know if the 4.0 was ever a real thing, but we don't tell our spouses all the specific details. They don't actually really want to hear about the work at the end of the day. So, but what I will tell you is that we've always embraced new grads. But our new grad program was very limited in size. So it was small. I mean, maybe at most 40 new grads a year. We have quadrupled that just in my market and gone up to, I think we've got about 160 on and coming on new grads. That's a dynamic shift in how your operations work, right? Because where do most new grads get stuck? The night shift. You can't run a hospital with 100% new grads on the night shift. So you have the staff you have, how do you engage them in that continued learning for the new grads? So we've built kind of a nurse residency program. We've elevated that continued learning beyond nursing school and using rockstar high-performing nurse leaders. They are not necessarily educators, but they are nurse leaders, and they're from varying units. And all these new grads get to cycle through all the various units. They get to be a part of deciding which unit they're going to work in. But nursing profession, you cannot just take a new nurse out of school and drop them on a floor. And if you do, you won't keep them. The other challenge from 2020, as you mentioned, and I could call it self-inflicted injuries, but the rules are what they are. We lost a tremendous amount of nurses, FYI, rev cycle people too, but not as many. A lot of nurses over the vaccine mandate. And I don't know if any of y'all experienced that, but a lot of healthcare workers left over vaccine mandate and are still, quite frankly, in a state of limbo for the most part. We also lost a lot of people to burnout. COVID has been a journey for clinical personnel. It's been difficult for everyone, but for the clinical personnel that are in the hospital in the N95 all day long, it has become incredibly burdensome to be in healthcare. And so I think that, I actually believe, and yes, I'm a CFO, but I'm going to say it anyway, there's a little bit of benefit headed our way potentially with the big R word that nobody wants to use, right? The recession. There are a lot of people who made a choice to exit not just our industry, but a lot of industries throughout the course of the pandemic. If we do enter a true recession, there may be people who are going to have to make a different choice and come back to work. So how do you have the level of engagement with your recruiting teams to consider people who left and keep staying in touch with them. We are big on re-recruiting those who left the organization, regardless of why they may have left the organization. Now, obviously, clearly we don't want everyone back, right? But I would say to you, the bulk of people who leave aren't really the ones we want to leave, right? That's good old Quint Studerism right there, right? Your low performers aren't the ones who voluntarily exit most of the time. So, we do engage with HR and our recruiting partner. We do all that due diligence first, and then we go to, maybe it's the nurse unit leader who had that caregiver before, who, by the way, probably knows why they really left. And we're starting to proactively reach out to people. They've had some rest, the ones who left over burnout. They've had some rest. How much do you want them back? Start with some of that. So, but yeah, no, we're not doing 4.0 GPAs.
I would echo that sentiment on welcoming people back that have left, and that's always been our philosophy. We've had people leave and go work in one of the larger cities around us, and they come back, and oftentimes they have a fresh perspective. They're not in this echo chamber of a few nurses that have seen the same patients, treated them the same way. They've seen how other facilities operate, and sometimes they say some pretty nice things about us, and let the nurses that are there know that it is a nice place to work. So that is something that we've always done. Again, we don't demand 4.0s, and we do see, we do have a lot of green nurses come in and start working with us. We had a conversation with the nurse supervisors last year and asked them, what are the huge pain points? And one of the things they said was training. In that same situation of, you can't put all the green nurses together, because then you have one experienced nurse and she spends all day telling everybody else where they're supposed to be and what they're supposed to do. So trying to balance that, but then also we were in a unique position. We'd recently hired an RT that had experience running a sim lab. So we're in the process of getting that started, of having one of the sim mannequins that can do all kinds of very neat things, and it better for what it cost. But there's no replacing the experience you get from actually seeing something that is coding, right? And our nurses might see that 2 or 3 times a year, and it's always under the very panicked life or death situation. So why can't we just give them the experience of keeping that training going, giving them that muscle memory so that they're not panicked when they see it the 2 or 3 times a year? So things like that, we're definitely trying to keep our nurses engaged with. You're here not because not every hospital is the same, right? And yes, you can go somewhere else, and we can't necessarily compete on price, but can we give you a good experience of working here? So.
During COVID, we lost probably 6 or 8, not a very high percentage at all, of nurses who took bonuses and went to work for the big city hospitals, right? Cadillac and Trios and some of these others for their signing bonus. And a good number of them have already said, as soon as my time is up, I'm coming back, right? And so we use culture as our driver.
And we had the same experience. We actually had a couple nurses that left for agencies, and they were still living in our town, and then they were working for us under the agency. But we really worked hard to just, again, welcome them back, let them know how much we wanted them to be, a part of our permanent team and really vested with our staff. And we don't have a GPA limit either. We actually have a community college in town that we partner with, and we offer, we educate and have them come on site to do clinicals, and then we really encourage hiring them on as a CNA, and then working with them to empower them and to continue to get their LPN and RN license, and really talk with our own staff, because your staff is your best recruiter, right, to create that wonderful experience, because we want them, when they do get certified, to come back and work with us permanently. We have a unique situation where we have 4 other critical access hospitals within a 60-mile radius of us. And so they do rounds at all of those other hospitals as well. And so it's really important that we make their experience one that they want to be a part of our team.
You've talked a lot about culture, which I really appreciate. I think in any setting, that's probably, I agree, the most critical part to the success of every other aspect. One of the things I noticed was the people who stay seemed very resentful of those coming back. Like, I've been here the whole time, you're the one who left, you got money for going, you've gone out and had your rest, I've been here the whole time, I'm not helping you, you need to take on the grunt work, you need to kind of like make up for your treachery for leaving. And so even if the leaders don't feel that way, I've noticed that other staff on the team or other nurses have demonstrated some of that. How are you addressing that internally, making sure that the people who did stay and stick it out, quote unquote, are also welcoming those people back or feeling appreciated for what they see as their sacrifice or their loyalty? Have you run into that at all in these smaller communities? I would almost think it could be more stark in a small town.
I'm not aware of that kind of feedback. Most of the time it's, aren't you glad you're back, right? And they're happy they came back. Generally the ones who have left have been the ones who are very young. And so I know our CNO, she said, I actually like this, right? They're recruiting away our junior nurses because they're throwing dollar signs in front of them, but they're giving them a 3-year education at a higher acuity level, and then we get them back because they didn't like working there, but they learned a lot. And so then they come back and it's like, so, no, because, if your culture is about respect, that doesn't stop, right? Just because of that, so.
It helps when the nurse who stayed is the mother of the nurse who left. So.
We haven't experienced that, but we also took a hard line with clinical personnel that left for traveler assignments, couldn't work in any of our facilities as travelers. And we actually, throughout the pandemic, had contract labor went up tenfold for us in volume as well as cost. And so what we experienced instead was incredible angst with the rest of the workforce, because it was well known what these traveler RNs were earning. So we've been having to address that all along to have creative ways of engaging with all of our nursing levels, being transparent to the extent that we can. But there has been a tremendous amount of bad feelings for those who stayed with their organizations. There's also some jealousy, right? Some of the nurses are jealous of their former colleagues that got to go hang out in San Diego for a 6-month assignment or whatever the case is and make $1 gazillion, because not all of them have a family situation or life situation that they can be on the road traveling. So we did see some of that where there was more envy than anything. But we had a lot of wage disparity challenges. I think many of us do. Just over time, you get behind on market. We've had to do some creative things with our unions and really get wages further up to market, as many of you have experienced. So that calmed some of that down. It's always administration. They're not mad at each other. It's administration.
The feedback that we've gotten for the most part is the nurses that stayed are super excited to see the other nurses come back, to be honest. And it's also great to hear, since we've sort of built our management and executive team and we've seen a shift in employee morale, that the nurses that are coming back are just feeling great about how things are going and in the right direction. So hoping that that'll increase our retention. And so yeah, that's what we've seen for the most part.
My question's around outpatient behavioral health, and if your organizations are kind of confronting that issue or meeting that need in your communities. That's for us. So I work for the leadership of a hospital in Fairbanks, Alaska, and that's, it's a huge community need. I understand it's probably in your rural communities as well, but something that's just when you're doing the business planning is really hard to pencil. What has that been an issue you guys have confronted recently?
We're trying so hard. I mean, it's exactly what you said. It's so hard to find a means of doing it that we'll get paid for, and that's sustainable. at the end of the day, because, you know, just including it as part of primary care, it doesn't have to be profitable. It just needs to be sustainable. You know, one thing that will help is in January 1st of 24, we can start having, I'm not even going to try with the acronyms, but the two counselors, the two types of counselors, LM, whatever. Anyway, they're expanding the credentials that a counselor can have and provide behavioral health out of an RHC. That'll be great because I think it's going to be easier to recruit some of them to Dayton than it would be than it has been for an LICSW. You know, there just aren't as many of those.
So I would add real quick on that, because here's yet another gift of the pandemic, right? We kind of call it the fourth wave. The gift that just keeps giving. I can tell you, and it's not just my organization, I see this across the country, the prevalence of workplace violence has skyrocketed. The prevalence of behavioral health issues after people were forced to be locked down for as long as they were have manifested in interesting ways. And we are seeing much more aggressive behaviors in this pandemic period and beyond than we've seen in the past. So my challenge to you would be, think about your return on investment in a different way. I have had caregivers who have suffered assaults that have had them out of the workforce for some time because of the level of aggression from patients. We do have investment in behavioral health. It's not enough. You have to go beyond the walls of inpatient. You need a whole continuum that includes an outpatient focus. And I think that when we stop thinking about things in terms of just the hardcore black and white of a pro forma, and you start looking at the morale impact, your risk mitigation. I look at an investment in behavioral health services as very heavily on a risk mitigation side. We can't just look at it from the what am I going to get for this particular service. So think about it in that lens and really track and trend with your clinical folks closely, your incidents. We meet every day on this, every morning. Your incidents of injuries in the workplace and how many of them are related to workplace violence. It doesn't take very many of those to pay for funding a behavioral health program.
Time. Well, thank you so much, panelists. This was awesome. Round of applause for our panelists here.